Okay, now we're at week 2 for Introduction to Biostatistics. This is a seminar series that we hold every summer. It's co-sponsored by the Department of Biostatistics, the Cancer Center, and Frontiers. My name is Jo Wick. For those of you who were not in attendance last week, I am a biostatistician in the School of Medicine. My faculty position is in the Department of Biostatistics. Our offices are on the 5th floor of Robinson, so if you ever have a statistics need, I hope that you will try to come find one of us. Feel free to email me directly, and I can give you the information for how to get some statistical support. The lectures are being recorded and posted at our department's webpage. If you navigate to biostatistics.kumc.edu and go on the left-hand menu, there's a tab called Events and Lectures. And then when you click on that, it'll show the title of this. The lectures are the recordings are processed right after, so it takes a couple of hours, and then our Dinesh puts them up on YouTube for viewing, but you can access them at all times from there. And they'll be up for the remainder of the year, so if you ever want to go and access some material that maybe is relevant to something you're currently working on, feel free to do so. The objectives of the course are not to make you a statistician, it's just to give you a refresher in some of the language, specifically around the role of statistics in the scientific process and medical research. We're going to focus today on experimental design and how that relates to the strength of evidence that's generated by a study. So we'll look at different study designs that are commonly employed, and we'll talk about exactly what differentiates each one from the other and why those differences result in either strengths or weaknesses for the scientific evidence. So again, a high-level overview of statistics will start today because we'll be talking about design of experiments, which is one part of the process, and then next week and the 28th of July we'll get focused on the actual analytic methods. So how do we do hypothesis testing? What is it, first of all? And then how do we implement that kind of method to tackle some common research questions in the context of different study designs? So we'll go over things like randomized controlled trials, or where you have two groups and you're comparing their average responses or their response rates. What methods would we use to do that, and how would we interpret those results? Survival analysis is one that's very, very common, and regression techniques. So some of those things will be covered in the second 2 weeks. But today let's get into this centerpiece here, which is the design of experiments. I defined the field of statistics last week as the science of decision-making in the presence of uncertainty, and everything that we do for the most part can be bent into one of these three things. Descriptive statistics, which is kind of exploring data. Inferential statistics, which is what we think of as analysis, analytic techniques for drawing conclusions, making a yes or no decision about a hypothesis. And then underlying everything, it's really the foundation of evidence of scientific data is the set of tools that fall into this term experimental design. Last week we talked about the language of statistics. We covered a little bit of the vocabulary around hypothesis testing and design. We talked about levels of measurement, graphical and numeric summaries. So we focused a little bit in on the descriptive statistics aspect. Today we're going to cover that middle, and then the next 2 weeks will be spent on the analytic pieces. Experimental design is focused on planning and conducting studies in a manner that minimizes the impact of bias and therefore strengthens our conclusions. In statistics, well, in research in general, I think most of us think about statistics at the end because we think of it as a tool for visualizing our data and for doing a hypothesis test or regression modeling. But the truth is, the bulk of the work really needs to occur at the very beginning of a study, before you've ever even seen a patient or you've taken a sample, a measurement in the lab. because we need to employ techniques to ensure that we end up with a valid and reliable estimate of a treatment effect. Most of the time, whenever I meet with an investigator, they are interested in how they should analyze their data. Well, there's two questions. How many patients or subjects do I need, and how do I analyze my data? So if we think about that being the end goal, which is the data analysis, which would result in an estimate of something that addresses your research question, determining how we define that analysis plan requires us understanding a couple of things. We have to understand the context that generated the data. So what was the study? Where did the data come from? How was it collected? What was it collected on? When was it collected? What was it collected by? What is the research question that's being addressed? We have to understand the actual measurements. This is actually something that seems very straightforward, but whenever you're in a collaborative meeting, it often is not clear that the statistician is asking you, is your outcome continuous? Can we assume that it's normally distributed? Is low good and high bad, or vice versa? How much data do you have to work with, meaning how big is your study? And then once those things are identified, there should be at least a subset of methods that would be appropriate depending on what the eventual data actually looks like. So does it look nice and symmetric? Do you have a lot of outlying observations? Is your data skewed? And so forth and so on, because those things can impact how you analyze it once it's in hand. So these concepts can be lumped into very simple statements around the design of the experiment, the research question or hypothesis, the level of measurement, the sample size, and then the assumptions of the analytic methods. Everyone knows the assumption of the t-test, right? What's the assumption of the well, the one that most people think of whenever we talk about the t. What do you have to have? Normally distributed data, right? So that's what I mean when I say the assumptions of the analytic method. You have to check those. Otherwise, the test statistic that you get is not what you think it is. It's not measuring the difference between what you observed in the data and what you expected under the hypothesis. So the steps in design, we have to formulate testable hypotheses, determine the treatment groups or the experimental conditions, how we're going to collect measurements, and what other things we need to control, either through a controlled environment for our study, limiting our population to a certain more homogeneous group of patients, or there are many ways of controlling. We have to determine the appropriate sample size, which we will also get into, and then how will we assign subjects, preferably in some random fashion, and then, of course, determining the statistical analysis that will be performed on the data that results from the experiment. All of these things, even if that went in one ear and out the other, the purpose of any of these tools and any of these steps is to minimize bias in your data when you get done. So you get a sensitive test of an effect and a reliable test of an effect. Some of the methods that we employ include randomization or random sampling, control groups, and blinding. And we'll go through each of these specifically today, and we'll show you which designs employ which of these techniques. The more techniques that are employed in a particular study, the stronger the level of evidence is that's generated by it. So let's get first to how we sample from a population. The gold standard would be the random sample. This is not always feasible. In fact, we very often don't deal with random samples. We usually deal with convenience samples in medical research because we have to work with the patients that we actually have access to. For all intents and purposes, as long as we're transparent about how those patients are selected, and how the study subjects were actually enrolled and recruited, then we can assume that it's close to a representative sample of the population. The key behind random sampling is that theoretically, in theory, if you don't take into account any of the subjects or the patient's characteristics when deciding whether or not to enroll them. For instance, you're treating patients in a clinic, you have a clinical trial that's ongoing, you see Joe, and you really think whatever it is about Joe, this, I'm going to say girl, because I'm a girl, my name is Joe, this girl is really going to respond. I think she's going to respond to treatment. I'm going to try to get her on study. Bob really is the same as Joe. I mean, he's a guy, but he's a little bit different. He's going to respond differently, but your inherent bias is that he's not the best candidate. He meets the criteria for the study, but something about my knowledge and my experience tells me he's less likely to respond to the treatment, so I'm not going to maybe push as hard or those kinds of things. So if we take into account subject features when deciding who's part of the sample and who's not, we break the protections against bias. It's something called selection bias. So doing this in a random fashion where we approach all people who are eligible should theoretically give us some protections against systematic features that may occur in the sample that could affect or bias our outcome. Did someone type a question? No. So the key here is that if the sample accurately reflects, if it's representative, if it's taken in a pseudo-random fashion, then the information contained in the sample should be a good estimate of the true population characteristics. So if you're interested in the population mean, taking a random sample should give you a sample that accurately reflects through its own mean, its sample mean, what the population average likely is. The key, of course, is making sure you're actually sampling from the population of interest. And this is where we get to generalizability later on. Yes?
So you're saying that there would be selection bias if the clinician was putting patients into groups of the clinical trial based on their assumption that one would do better, one would not, right?
That's, yes. So can I repeat the question? Because I think last week they had an issue of hearing the audience. So your question was, if you have no random component to assigning a study subject to one of the treatments in the study, that's also selection bias. What I was talking about was more trying to get to a representative sample. So you will end up with a biased sample. Let's say we only have one treatment. Let's say we're doing like a pilot study. We're just doing 10 patients on this new therapy. We want to see if it's safe at the dose that we've got. If I am deliberate about picking certain types of patients and excluding others, and that's not written down in my protocol, then I have a biased sample.
So my kind of question about it is, if you truly went after a random assignment and ignored your knowledge base that this person would respond more than the other, is that even ethical?
Okay, I see where you're getting. We will get to that. That is where I think the whole idea of conducting experiments in humans becomes very muddy. The answer is yes. Under certain conditions, it is ethical to randomize. But certain conditions have to be met. And we'll talk about that when we get to next week's, when we talk about hypothesis testing, specifically in the context of a t-test. You have to have assurance in terms of like a benefit-risk profile, and that that the current state of knowledge is that we don't know which is better. It could be either one. But if there's a strong evidence that one is better than the other, you shouldn't be doing a clinical trial. It's already been done. Someone's already generated the data, so why are you doing another one? Unless there's some other unaddressed question or you're trying to replicate. Okay, so random assignment. So we talked, just to be clear, we were talking about getting a representative sample by randomly sampling from a population. Random assignment we use when we have multiple groups, multiple treatment groups in a study, and we want to ensure some protection against what are called nuisance variables. So when we randomly assign treatments to patients, treatments to study subjects, it increases the chances that other factors that may affect the patient's eventual outcome or response to treatment are distributed equally among the groups. So when you get done with a study, those two homogeneous groups will have some average response that may differ. And if it differs, you are pretty confident that that difference is either associated with treatment or can be directly tied to the treatment effect. And so random assignment, again, is that assurance. It ensures that the groups being compared are homogeneous. They differ only by the experimental conditions of interest at baseline. One word of caution is that randomization is a protection that fails in small studies. If you think about it, it's very easy. Just think about flipping a coin 5 times. What are the chances you're going to get, 6 times. What are the chances you're going to get exactly 3 heads and 3 tails? There's chances that you could get all 5 of them or all 6 of them to be one or the other just because you did so few coin flips. So the idea is, in the long run, for larger samples, randomization will balance out those confounding factors. Nuisance variation is any undesired source of variation in the outcome. We talked about this last week in the context of the workplace toxin and smoking exposure problem for infertility. There are 2 ways nuisance variation can impact the validity of your study. It can result in bias, where that nuisance variable or factor systematically distorts the results in a particular direction. It either makes it look better than it actually is or makes it look worse than it actually is. Another way is it can just increase the noise in your data. So it just increases the variability of the outcome being measured. And that decreases the chances that you'll be able to detect a signal because you have too much noise. Yes?
Is there like a specific number, or like after that number, you're kind of still comfortable that randomization might balance the confounder and both rules?
Oh.
Honestly, the number is probably lower number.
I don't know. Okay, so the question is, is there like a number where randomization is ensured to work? I think as the sample size grows, the chances it's working grows. So there's not really like a magical cutoff. But I think if you read like statistics books and things where we really want that, that black and white decision, 30, I think is where most people, kind of cut off between small and large. I don't know that that's a valid cutoff. That's why it's always important at the end of any study, even big studies, to just look to see if your groups are homogeneous. And the key is, even if they're homogeneous with respect to all of those factors, it doesn't necessarily mean that you don't have an issue with nuisance variation. But at least it will ease your mind a bit to see that they're homogeneous. Control groups is another strategy we employ in design to minimize the impact of bias. The way it minimizes the impact of bias is it allows us to actually measure different kinds of biases. So one type of control, which you don't see that often because it may have ethical implications, is called a negative control or an untreated control. Sometimes it's called a null control. If you include a negative or an untreated control, that group of subjects would allow you to measure what changes in a patient's outcome are likely simply by observing them. So an example of this would be, and I think that this is probably a place where it might be ethical, is to take a look at, to include in a study of migraine medicine, whether or not migraine sufferers, when left untreated, when they don't take a pill with an active ingredient, whether they see some relief in symptoms simply due to the passage of time. because that ailment does resolve on its own at some point. So if we failed to take this change in outcome into account when we're looking at the actual effect of the treatment, we may overestimate the effect of treatment because some of these individuals may have resolved simply as a function of the disease process as opposed to actually having an effective treatment. And having a negative control or an untreated control would actually allow us to measure that expected progression of the disease or resolution of the disease and compare it to what's observed in individuals who are actually treated with a drug. Another kind of control, which is one that's seen very often in medical research, is the positive or active control. This is usually a standard of care, what's already been developed, some therapy that's already been developed and has been approved to be used in patients in the clinic. And it may vary from hospital to hospital, but the idea is if you include this condition, this arm, in your experiment, we know what should be happening to these patients when they're treated with the standard of care because we've been treating them with this for a while. So one thing that this positive condition or this standard of care allows us to do is to make sure our experiment's valid. If we see unusual changes in that control group, we might want to take a closer look at what we're doing. It might be that we're not applying the treatment to the right population, for instance. An example of this kind of control is the use of an existing chemotherapy in the clinical trial of a new therapy. If subjects don't respond as expected to that existing chemotherapy, which has been used in the past, it may be that there's something wrong with our experiments. This is one of the ways that the control group will allow us to ensure that we have a good estimate of a treatment effect. It also gives us a kind of a baseline comparison for the treatment effect if we want to show that it's as good as what's currently out there or better than what's currently out there. It's the standard by which we are doing the comparison. You can, because what if the person who's administering that particular treatment, and I'm saying for it's chemo, it's an easy example. What if the person who's administering the treatment's new and they're not doing it the right way? Or what if you're not measuring the outcome the right way? You know what I mean? So it's just a test of validity because you should know what to expect, and if outcomes in that group deviate far from what you would expect in clinical practice, then there's something wrong with the experiment. Yes, execution of it, yes. Yeah, it's a red flag, a warning that something's not going on right. A placebo control, I think everyone knows what this is. It's the most well-known effect in clinical trials. It's just the power of suggestion, and it's been demonstrated to actually exist, and it's pretty strong. The problem with a placebo is a sham condition. If it's a drug study, then they're getting what appears to be the exact same drug as those who are in the treatment group or the treated group, except their drug has no active ingredient. It looks the same, tastes the same, smells the same, they take it in the same way, except it has no active, it's missing the active ingredient. So these sham conditions, even taking a pill can produce a real response in a subject. So it's measuring that effect in patients to ensure that the effect that we observe in the treated group can be attributed to the active ingredient as opposed to the act of taking a medicine. Blinding is another protection in design. It simply removes the knowledge of the experimental condition from certain individuals that are involved in producing an outcome in the clinical trial. So if it's a single blind, we are blinding the patient only. A double blind is usually the patient and the physician, the person who's observing the patient's response. And then a triple blind, which you don't see as often, but I think is very interesting, is not only is the patient and the physician blinded, but the person who's doing the data analysis is blinded to which treatment's which. This is a nice blind to put into place, as we'll see next week when it comes to all of the different things that can affect what it is that we're doing from a data analysis perspective. One particular type of study that, if a study doesn't incorporate any blinding, you usually hear it being referred to as open label, which means everyone knows. Yes?
If it's triple blinded, how do you know that the blinding actually, and how do you know that everything occurred like you wanted it to, nobody's watching it?
Well, you do after you do the data analysis. So what I would produce as a statistician, so the question was, if the statistician's blinded, how do you know what the results mean? You generate the results, and then you take a look at them, and then you unblind. So I would get like group A and group B, not knowing which one's which. Yes?
I'm actually going back to the
Okay.
placebo versus negative.
Mm-hmm.
If you run a placebo control, can you actually refer to that as a placebo effect? Because you haven't controlled for the negative.
You could
It would resolve itself, right? Versus placebo. The placebo is just too powerful.
Yeah, so the difference, so what it is that a placebo is measuring, it could be both, right? If this disease is acute, meaning it resolves quickly, then every study subject on the trial, part of their outcome will be attributed to the resolution of their disease, the natural resolution of their disease. But we'll modify that trajectory with a placebo, so we'll probably increase it. We'll increase it because they'll improve more quickly, maybe. And we would further modify that trajectory with the active treatment if it's effective, because then that would really result in a quicker resolution. So the answer is yes, that effect is always there. Is it ethical to measure it? Is it necessary to measure it? In an acute study, or a study of an acute disease where it's ethical to not treat someone, measure it. Have a null control, have an untreated control, and you do see them when those conditions are met. But I would say probably for the vast majority of studies, there's either an ethical issue or it's just not necessary. They don't, the disease is chronic maybe, or maybe they understand its progression well enough. So when we evaluate, let's say we're sitting down and we're reading the literature, we're trying to figure out how to treat the patient that's coming into our clinic tomorrow, and we kind of want to review the current state of evidence. A new study came out in the literature, and you have to figure out where it fits in. How strong is the evidence? There's a couple of things that we have to consider, and they all really relate to the design, how the study was designed and conducted, and that really depends on the transparency of the publication. So for those of you who have published in the clinical trials literature, there are a set of guidelines that give you the necessary pieces of information you must include in a manuscript to report the results of a clinical trial. Does anyone know what those guidelines are called? Consort. Yeah, consort guidelines. So if they're for randomized controlled trials, that's where they started, but they actually have consort guidelines for a variety of different types of studies. They have guidelines, similar guidelines for doing meta-analysis and reporting how a meta-analysis was conducted. So make sure that you understand the minimum amount of information you need to provide to a reader for them to understand exactly what it is you did. Ideally, I know journals have like page limitations, but appendices can be added. You can publish it on a website, those kinds of things. There's ways to get the information out and then refer out to it. Make sure that you give people the recipe for conducting your study so they understand the study's validity. And I think we're moving in that direction in the literature. I think it's more emphasized now than it was even 10 years ago. So when you're reading a quality article in a journal who requires that authors publish according to consort guidelines, you should be able to assess all of these different things, whether or not the design itself was strong enough to permit a calculation of a valid estimate of the treatment effect. Does the data collection procedure produce reliable results? In other words, if I'm measuring two individuals who are identical, do I get identical results? If I measure the same person, is it sensitive and reliable? Is the study powered? We'll talk about power next week. But in other words, is it big enough to really find the signal in the noise? Does it provide maximum efficiency within the research constraints? Maximum efficiency means that they used enough study subjects to answer the question. They were adequately powered, but they didn't use so many that they found meaningless effects. So it's like an overpowered study. You want to meet that sweet spot. And then, of course, does what they're doing conform to the accepted practices and procedures used in your research area? With that being said, the different types of study designs that you'll see in the literature can be put into for the most part, I always have to there's a star next to everything that I say, right? Because there's always an exception to the rule. They can be put into one of these bins. They either serve to describe patterns and relationships and classify and explore, which are descriptive studies, or they're designed really to test hypotheses, which are called analytic studies. There is overlap. You might test hypotheses in a cross-sectional study. I'm not saying that you shouldn't do that. It's just that the strength of evidence really in terms of confirming a hypothesis is really out here on the right when a lot of the protections are put into place. So along the bottom here, I have an arrow pointing to the right that shows that as you go from left to right, you're increasing the complexity of the study. There are downsides to that. Obviously, the more complex it is, the more costly it is, the longer it takes to do it. But the payoff is that your confidence in the results is much higher because you've employed all of these techniques or a subset of the techniques to minimize the impact of bias on the treatment effect. Very often you'll see this in the pyramid form to show, again, increasing complexity and increasing confidence in the results, starting with studies that really are not experiments at all. They're more they're epidemiology. You know, you take a snapshot in time or you view a population in its natural state and take that existing data and try to look for associations to generate hypotheses that could be tested in a true design study. Case control, cohort, randomized controlled trial, these are considered primary studies. They are designed, they employ some techniques from design of experiments to minimize the impact of bias. Sorry about that. And then at the very top here we have the systematic review and meta-analysis. And I'll talk briefly about what those are because you do see them in the literature. But the idea is the higher up on the pyramid, the stronger the study design's results should be if it was conducted in a manner that adheres to the scientific method. So let's start at the bottom with this cross-sectional study. And I mentioned that this is generally not a designed study. When I say not designed, I mean it's not employing a lot of the techniques for experimental design. There's not necessarily a control group. There's not randomization. There's not blinding. Usually it's based on data that's already been collected for some other purpose. So it is a descriptive study that is designed, and I'm using the word designed here loosely, to assess the association between an exposure and an outcome. That exposure could be smoking. It could be, a lot of sunburns over the course of life. It could be level of education. It could be high cholesterol. It could be many different things. It could be an actual treatment, a drug for high cholesterol. But the idea is the exposure exists. No one randomly assigned it to the study subject. And then some outcome. The idea behind the cross-sectional study is that the selection of study subjects really is defined by not only just whether or not they have the exposure, like in a cohort study, I still get them mixed up, but also by their outcome status, whether they're a case, like a diseased subject, or a healthy subject control. So you calculate or you record this data simultaneously to determine who's actually in your study. So there's no directional, there's no temporal relationship between exposure and outcome. It's a single snapshot in time. And I want to pause here for a moment to make sure that I define some terms that I'm going to be using. Cross-sectional studies are neither prospective nor retrospective. And these terms are used a lot in medical research. These two terms describe when the cohort is identified relative to actually observing the outcome, for instance. So if it's a prospective study, I'm identifying my cohort or my study subjects, my population at the beginning, and I'm observing them through the future. So it's prospective observation. Retrospective means all of the data has been collected in the past. I'm defining a population at the present point in time and then actually using historical records. I'm looking back in time to gather that information. So there's no prospective observation, and there are strengths, benefits, and downsides to both of those that we'll get into. But a cross-sectional study, as it falls at the bottom of this pyramid, has no temporal component, so it's neither prospective nor retrospective. Another aspect of these studies that impacts what we can do with the outcome data is the descriptor forward directional versus backward directional. Again, nomenclature here, but forward directional refers to the fact that the exposure is observed first and then the outcome. So I start with the exposure and I look forward in time, either prospectively or retrospectively. Time could be the present or the past, to find the outcome that occurred. So I know that the exposure occurred here, and I go forward in time to find the outcome. Backward directional means my direction of inquiry starts with the outcome and then looks back in time to find exposures that could have caused or increased risk of the outcome. It's a lot of words, but I'll give you some pictures here in a minute to hopefully clarify those two things. So this is the cross-sectional study. I'm going to go forward really fast to show you in the case control study. Let me see if I can minimize this for just a second. In the case control study, where we do start to get time as a component of the design, there's a time axis. So I indicate where the present day is and when things are going on. Notice in the cross-sectional study that doesn't exist. There's no time axis. So we define our population. We gather existing data, whether it be from other people's studies, other people, I can't even think of the word, when people keep a registry of patients, medical records, patient charts. We gather that information and we look to identify exposure and outcome. So what kind of drugs were they taking for their cholesterol? And did they eventually have a heart attack? So it's all a single snapshot based on historical or currently existing data. And then we generally classify them either as having the exposure of interest and then getting the eventual disease or not. So there's 4 groups here where the combination is of their exposure status and their disease status. This is a simplification of this because the exposure might not be a yes-no variable. It might be somewhere else on the level of measurement. It could be a continuous measurement. And the outcome may also be continuous. The outcome could be how long it was before they had a stroke, for instance. So the idea is to look for an association, whether that association is described through this kind of format or through like a scatter plot of continuous variables. So you're just looking for associations. But the key here is in a cross-sectional study, we don't have assurance that the exposed and unexposed groups are similar in all respects with the exception of the exposure, which is the assurance that we get when we employ randomization. So we don't have randomization, so we have sources of bias that could crop up here. There could be a lot of things that are unmeasured that could make it look like we have an association between treatment and outcome or exposure and disease that are just not available to us. Nor do we know the temporal relationship between exposure and outcome. We didn't observe and then look back in time. We just know that it exists for each of these patients. We classify them into one of these groups. How do you define the population? So, you could do a survey, just a survey of, it depends on your research question how you define the population. So what is your goal? So I'm trying to think of when we've done maybe a cross-sectional study. Maybe I want to know patients that are treated at KU Med. I want to know what they're being treated with, or maybe I want to know how they're, let's think of something outside of cancer. Diet. No, it's related to what because the factor, the exposure, is part of your research question. So, if you were doing this study, a cross-sectional study at KU Med, and you used Heron data, for instance, which is a research tool, I'm not as familiar with it, that pulls from, I think, the electronic medical record. There's no temporal component to it. It's very difficult to do. You can do it, but it's very complicated to do longitudinal stacking data in an order of time. So all you can do is, if you've got patient ID, and you can grab their, I don't know what your research question is. You grab all patients that were treated at KU Med between January of 2006 and December of 2017, and you find the ones who have information on some exposure of interest or some characteristic of interest and some outcome of interest, and you see if they're associated. That's the simplest case. So yes, defining your population is, the definition of your population depends on what you're trying to answer. And when you get a hold of the data, if you're using a big data set, someone else's registry, you're going to have to pull some of those records out because they're not all going to be in your population. Your population, one of the pieces of the population may be they had to have been treated between this date and this date. They had to have been seen at KU Med. Maybe they had to be female and above the age of 50. And they had to have data available on use of hormone replacement therapy and something else. But there's no way, because of the limitations of the data set that you're using, which is pulling from EMR but doesn't really keep a temporal sequence, the best you can do with the resources available is understand whether they were treated with hormone replacement therapy and what their outcome is, whatever your outcome is of interest. And you collect all other kinds of information on them, and you can look for associations. But the idea here is that, yes, that definitely plays a role into your defining your population.
I just had an idea, okay, so let's say you're using an EMR and there's this one clinic that doesn't collect piece of information, that do you expect that
That's the real world, yes, yes. So,
representative of the population because you don't know. You
correct.
didn't know that the yeah.
So, the question was, what if you're using data from EMR and it turns out one clinic in your system is not collecting this important outcome. So you have to, let's say you exclude that clinic. You don't have a truly representative sample. So again, when you're published, I mean, unless you go back and tell them to collect it, which is not going to happen, or to enter it in, that's a limitation of the study. It's just a limitation.
That you thought they were collecting it, but they weren't.
Yeah.
So, I mean, then that's not really, I feel like that's a good example of how a limitation of a cross-sectional study as opposed to the next one above. Because then you make sure that they're doing it.
Like a perspective, yeah, figure out if they're collecting it or not. Yeah. Yeah, missing data is a huge issue, a huge source of bias.
So you talk about nuisance variables here,
Mm-hmm.
right? Defined through population based on history rate, and then there could be other underlying
Mm-hmm.
variables. I'm assuming some of our recent cross-sectional studies with the biostatistics, people that counted for that, they looked through the data set, but
Never assume. Never assume that they've done their due diligence unless they state explicitly that they did their due diligence. If they don't state it, they didn't do it. That's the assumption that you have to make.
okay, if they make
If they make the statement, you have to trust their word.
no, they're working under the premise that the nuisance variable
That they measured it. And so in the limitation section, they have to talk about all the other unmeasured things that could have caused this, but we don't have access to that data. So you talk about that. So if you're a peer reviewer of a publication, someone's publishing in your field and you know this science, you know what those things are. And you can say in the review, well, where is this important factor that will modify this relationship drastically? And they'll have to say, if they didn't already state it, we don't have that data. And that happens a lot. I mean, but you have to state that in the limitation. Hopefully you think of those. And that's what the peer review process is for, is to pick up on those. Because it doesn't mean that evidence is not worthy of being published. It just means you need that information to to understand where it falls. Yeah. You know now you need to go design a study with that variable being collected to make sure that it's valid. So the strengths and weaknesses of cross-sectional studies, I think, are pretty clear. Their strengths is they're quick, they're inexpensive. You don't actually have to accrue, try to enroll patients and treat them and follow them through time. You can study actually several exposures and diseases simultaneously. So this gets to your question, like how do you define the population? Maybe your primary research interest is about women with breast cancer and hormone replacement therapy and some other thing. You have all the data on their treatment and their, all the data at hand. So you can actually look at many other different risk factors for whatever the outcome is. You can actually look at many other outcomes, positive and negative outcomes, because you're with the data. The idea here is, though, you're generating hypotheses. You're not confirming them. Generating it. Why? Because we don't have any protections against bias. You can also estimate the burden of the exposure on the population. So what fraction of this population actually had the exposure, what fraction didn't, and then the disease burden. How many had the outcome, how many didn't. Weaknesses is you can't determine which came first kind of thing. It's not, you can't verify it because you don't have the data or the information. If you could, then it would not be a cross-sectional study. It would then become, in the description, even if it's the same data source, if you have time, it would be a different type of study because then you could put one of those in front of the other. It would be a retrospective cohort or retrospective case control, something like that. You cannot identify incident cases. You can estimate the burden of the disease, but you can't identify new cases of disease because you only have a snapshot in time. You don't know if they were newly diagnosed or if they've had this condition for forever, or if it's a recurring condition. And one bad thing about this is if you have a disease that resolves very quickly, or a disease that causes death very rapidly, you could miss some cases, some acute conditions, and get a biased look at that. Because of the time, I'm going to, so this is an old study where they were looking at the association between cavities and fluoride supplements in the water. This is done in Newburgh, Kingston. The way that they did it was they just collected data on 2 different cities. One city had fluoride in the water, the other city didn't. And then they looked at the cavity-free rate of kids from clinical exams in these 2 groups. So there's no time component here. They just have the information about exposure or not, and they have information on clinical exams, whether or not the first permanent molars had any cavities in them. So data like this in cross-sectional studies, when you have an exposure and an outcome that are both dichotomous, you see what are called contingency tables reporting this because it's paired data. Every study subject has both an exposure and an outcome. So people who were exposed to fluoride and also had cavities, that's 174 of them here out of the 1,674 that were in the data set. And then those who were exposed to fluoride without cavities fall into that. And then you have, of course, the 4 cells in the table and many of the different measures of association we calculate as functions of those 4 cells. But the things that we can estimate from this kind of cross-sectional data include, again, the burden of the disease, the burden of the exposure, which is the prevalence. And so the prevalence is just the probability of having cavities given you had the exposure, or the probability of having cavities given you didn't have the exposure. So it's defined by exposure, and it's just the number who had cavities out of the total number who were exposed to fluoride, so 174 out of 734, which is about 24%, if my math is correct, and 501 out of 940, which is about 53%. So that's the disease burden, the prevalence of disease. The prevalence of exposure, or the burden of exposure, the exposure burden, is the same thing. We're just flipping what defines the group, the comparison. Here we're doing it by cavity status. Those with cavities, how frequently were they exposed? Those without cavities, how frequently were they exposed? And those rates end up being about 26% and 56%. And that's doing the column, 174 over 675 and 550 over 989. This is common metrics that you would see in a cross-sectional study. If the outcomes, again, were not dichotomous, you might see a correlation coefficient reported that would report maybe, you know, some continuous exposure and some continuous outcome, how they're associated. You could even do regression models, but the idea here is we're looking at association and not causation. Case control studies, that's one step up on the pyramid because now we have a temporal relationship, so it can be considered longitudinal. Case control studies are observational, though, by design. They assess association between an outcome and a past exposure. So you define your population based on outcome status. In other words, I have a population, some of them are cases, they have the disease, some of them are controls, they're healthy. Hopefully you can select your controls in a way that they're very similar to your cases in all other respects. That's one way that we can have a protection without, because of the limitation here is that maybe randomization is not feasible. I mean, it's not feasible whenever you're looking at disease. So, and then the observation is based on historical records. So you actually look back in time to collect the data on their past exposure. So it's based on medical records or subject recollection. So it's a retrospective study. And in addition to that, the direction of inquiry is backward because we're starting with outcome and looking back to exposure. Outcome first is where we start, and then we determine exposure. Sorry. Is that right? Yes. So this is the picture. If we think about the picture of the cross-sectional study, it's the same concept. You define your population based on some characteristics and, in addition, whether or not they have the disease. So we have cases and controls. And this, I've got a little mark here. This is a present day. When I'm doing this, I'm defining them on their current disease status. And then I have the ability to look back in time. I know, I can confirm that their exposure occurred in the past, prior to them developing the disease. So then I can classify individual cases as either having the exposure of interest or not having the exposure of interest, and those without disease, exposure and unexposure here. So again, an improvement on the cross-sectional study, because now we can confirm the relationship, the ordering of these things. But we still don't have the assurance that these two groups of patients, our cases and controls, are similar in all respects, with the exception of the disease. I should say disease, not exposure. Copy-paste error. That would require randomization to disease status, and that's neither ethical nor feasible. So it's just a limitation of the study, a limitation of the context. So these are, again, it doesn't minimize the need for a case control study, because these are very often the best that you can do under certain conditions. The strengths of case control studies is that they're quick and inexpensive. There's no prospective follow-up. Everything's already happened. You just have to define and go looking for the information. So they're quick and inexpensive. They're good for studying rare diseases. Why are they good for studying rare diseases? How are you defining your groups? Their disease status. Yeah, exactly. You know they have the disease. You don't have to wait and see if they're going to get it. So if it's a rare disease, if there's only 100 people with it, try to get all those 100 people's information. Try to get them to agree to participate. Or if again, the patients are already deceased, or you don't have access to them personally, but they had agreed to have their information collected in a way that would facilitate a case control study, then you could use that information here. So the idea is, if it's a rare disease, prospective follow-up to determine whether or not they eventually get the disease would take forever. It's also good for studying diseases with long latency, which means there's a long time between an exposure and the eventual development of the disease. If I started a study, if I did a cohort study, I have a group of exposed patients and a group of unexposed patients. If I had to follow them for 25 or 30 years before they started developing the disease, that's an expensive study. So you should start here with the disease status and look back in time, because it's easier to look back. There are, again, downsides, but it's more feasible in most cases. The nice thing about this, too, is you can study several risk factors simultaneously. Yes? I will do that. It has to do with the direction of inquiry. So this thing up here. So let me get to the cohort, describe it, and then I will make sure that I point out how it's different from a case control. The name will help you understand. The name case control, I think, from this point forward will probably help you remember how they're different. So you can study several exposures simultaneously, because as long as you have your cases and controls, you can look back and ask them all kinds of things about risky behavior or exposures, or look at their medical records back in time and see what all different drugs they took, what therapies they had, those kinds of things. So you don't have to have a single exposure of interest. You can have many if the data allows it. The weaknesses is that you can't estimate the risk of disease. It's inefficient for rare exposures, and it depends on the amount and quality of that retrospective data, so either subject recollection or some historical records. An example of this is cervical cancer and smoking. This is a study from 1982. It was designed to investigate the relationship between cigarette smoking and cancer of the cervix. So the study began by identifying 181 cases, individuals who had the disease, and then determining who the controls should be in order to hopefully provide a group of women who were very similar to the cases in terms of their age, race, what other things can theoretically increase your risk for cancer of the cervix. Any of those things. So they tried to be deliberate about matching up the controls to the cases to mimic randomization, if you will. And then they interviewed them all to determine their past smoking behavior. They found in this study that a much larger proportion of the cases, those women with the disease, had actually smoked cigarettes in the past, or at least reported smoking cigarettes. That data looked like this. This data does not look. This must be a subgroup of the 181 and 905 because it doesn't add up to the total. Oh, this is percentages. That's why. So percentage-wise, they found of those with cervical cancer, 15% of them had reported smoking. Of those without cervical cancer, only 5% reported having smoked in the past. So 15% versus 5%. One way that we tend to analyze case control data is through the odds ratio, which again is just an effect size. It's a measure of association for contingency table data. On the numerator, you put the odds of exposure in the cases, and the denominator is the odds of exposure in the healthy controls, and then you look to see whether or not those odds differ. The odds ratio, because it's a ratio, will equal 1 if the odds are equivalent in both groups, both the cases and the controls. However, if it's bigger than 1, that indicates that the odds of exposure, odds of having been exposed, given you eventually had the disease, are actually much higher than if you remained healthy. So a 3.4 here would indicate that there's a 3-fold increase in the odds of exposure associated with cervical cancer, where the exposure here, of course, is smoking, self-reported smoking. So the question was, how do I know it's a case control or a cohort, retrospective cohort study? A case control study, so a cohort study, let's stop here for just a second. A cohort study can be both prospective and retrospective, and that's why I think it's confusing, because you can actually begin a study and then have prospective follow-up, prospective observation of the subjects in the study. You could begin a cohort study and actually not have any prospective follow-up. You could just look back, you could ask them questions about, have them recollect things, or go back to their medical records. The difference between a case control study and a cohort study is how you define the population. So that in the case control study, I begin with cases. I begin with people with the disease, and I attempt to identify very similar controls as a comparison group. In the cohort study, I'm actually selecting the study subjects based on their exposure status, and then looking ahead in time from their exposure status, whether it be okay, this is where it gets prospectively or retrospectively, looking ahead in time at their eventual disease status. So let's do this simple. A prospective cohort study looks like a randomized controlled trial, right? Only I'm not randomizing to treatment or control. I'm just observing it. But that's how I define my groups. I have a group of exposed people, smokers, non-smokers. In a case control, what were my groups at the beginning? They had the disease or they didn't have the disease. So it's how you define your group. And then the direction of inquiry, because we're defining our group here by the exposure rather than the outcome, the direction of inquiry is forward. I go from the exposure to the outcome. Start with the exposure and figure out their disease status. In the case control study, I started with their disease status, and then I looked back for their exposure. So it's the direction of inquiry here. Whether that's done prospectively or retrospectively has to do with how I get the data. Prospective means I actually have to observe the study subject as we go to eventually get their disease outcome. Retrospective means they've already had the disease. I just have to get it from their medical record. Does that make sense? Because here's a retrospective cohort. Notice the only thing that changed here is that little thing on the bottom, which represents where we start the study. We either start it now and we follow the patients through, which is prospective observation, or we start it now and we have to go back in time to collect the data. But either way, the way we define our groups is based on the exposure, the treatment, if you will, in a cohort study, a group of treated, a group of untreated, so those are the cohorts, or the disease, which is when they are either classified as cases or controls. Case or control. Yes? Mm-hmm. You start with the exposure. That's really where your research question is. How do exposed and unexposed individuals differ in their eventual development of disease? The way that it's different from a cross-sectional study is in a cross-sectional study, there's no way for me to know from the data whether the exposure preceded the outcome, the disease. It's a limitation of the data. There's no time, there's no temporal component. If you have data that's reliable about when the exposure occurred and when the disease occurred, then you're not doing a cross-sectional study because you're going to report, right? You can report things like the time between when they were exposed and when they developed the disease. So it would, by definition, become a different kind of study. It's a limitation usually of the data that you have. So you'll actually see in the literature, you'll see people who do, so the reason that you do it a certain way really has to do with what you're trying to do. So if you're trying to study a rare exposure, you're doing a cohort study. If you're trying to study a rare disease, you're doing a case control study. You could actually do, and I saw an article earlier this year that was a case control. I'll find it and I'll attach it when I send the slides. The design was that it was a case control with a retrospective cohort analysis or something. It was a combination of all these things. And if you read it closely and you really understood what a case control design was and what a cohort design was, you understood why they incorporated features of both, because what they were after was a rare exposure, but they had access and actually defined things by whether or not the individuals had diseases or not, and they wanted to match up their disease status. So they did, it was a very, again, like I said, there's a star next to everything that I say because there's always an exception. Hopefully they are clear enough in their manuscript to describe why they did what they did. But again, the reason you would ever select one of these would have to do with the limitations of the data, of the research context, and really what your goal is. Rare exposures, you want to study more than one outcome. Or are you really after something that's a rare disease or something with a long latency? It just requires different types of approaches to answer the question. The question is the same, really, right? You're looking for an association between exposure and outcome, but the way you get to it in the most efficient way, in the most efficient manner, is dependent upon, how frequently is this disease occurring? How long does it take between exposure and outcome? All of these different things. But do you have the data on when it occurred? So cohort studies are designed to test association. You can have prospective or retrospective. In a prospective cohort, it looks just like a randomized controlled trial. You define your population. Rather than assigning, though, your study subjects to treatment or control, You actually observe whether they had the treatment or not, or had the exposure or not. So there's no randomization here. You begin with their exposure status, follow them forward in time to see whether or not they eventually develop the disease, or what their outcome was, what their response to the treatment was. So we don't have the assurance that the groups of patients are similar in all respects, with the exception of exposure, like we would in a randomized trial, randomized controlled trial. That's the limitation here. In a retrospective cohort study, it looks the same, except now we're not observing things as they happen. We have to go back and gather the data that's already been generated, either through the medical record or patient recollection. So we still have the same issues we had before. We don't have the assurance that they're the same in those two groups. But then we have the additional problem of recollection that could be compounding the issues. So cohort studies in general, they're stronger than the cross-sectional because they can establish the temporal relationship between exposure and outcome. In addition, a prospective cohort provides a more reliable record of the sequence between exposure and outcome because it doesn't depend on the quality of the record keeping. The downside of the prospective cohort is anytime you have to follow people through time, what happens? You lose them. You lose some of them. It inevitably happens. So any prospective study where there's prospective observation, it's going to cost a little bit more. It's going to take a little bit more time because the data has to be generated. And you're going to have issues with missing data, specifically as a function of loss to follow-up and some other issues. It is good for studying more than one outcome. You can define a bunch of outcomes that you want to look to see are associated with the exposure. And it's also good for studying rare exposures. So only a few people lived around some spill. You know, I don't know, I'm trying to think of like an epidemiologic scenario. So if you had like an outbreak and you knew they lived here, compare them to a similar population and see what the rates are different. The weaknesses though, it's observational, there's no randomization, so you have those usual biases. It's inefficient for rare diseases or diseases that take a long time to show up because you're following them, and that's the prospective cohort. Anytime you have prospective observation, you have issues with that. Anytime you have retrospective observation, you have to rely on the quality of historical recall. And another additional issue with cohort studies is that individual exposure can change over time. So if we think about the hormone replacement therapy, what if women are on it and then they're off it and then they're back on it? Or birth control, on it, off it, or smoking. They smoke for a while, they stop smoking. So it becomes difficult. There's noise and even bias that could arise because exposure status can change. So you have to be clear about how you define that. The Framingham study is the biggest example of the cohort study. They collected data prospectively on individuals to identify factors related to cardiovascular disease. They followed them forward in time to see whether or not they eventually developed the disease, and they were able to identify hypertension, elevated cholesterol, cigarette smoking as associated with that outcome. Analysis of cohort data, again, all of these, because of the way I've got it set up in terms of exposure and outcome, all of them look like contingency table data. We tend to report relative risk in cohort data because we're after the risk of developing the disease in people who are exposed versus unexposed. So risk is a measure of the number. So if we take a look here, this cell represents those who developed cardiovascular disease, who were exposed. So that you can think of them as the smokers. And this represents the number who developed the disease in the unexposed. So the risk of cardiovascular disease in smokers is A, the number who actually developed the disease, over the total number of smokers in the study. And the risk of cardiovascular disease in non-smokers is those non-smokers, the total number of non-smokers, how many of them developed cardiovascular disease. And a ratio of those two things, just like in the odds ratio, gives you an idea of the increased risk of the disease in the two groups. If the relative risk is close to 1, you're probably, that's evidence that they're very similar in risk of developing the outcome. So it's an evidence of like no association between the exposure and outcome. If the number is greater than 1, significantly greater than 1, then that would tell us that there's increased risk of cardiovascular disease in smokers. And finally, the gold standard of study designs, anyway, is the randomized controlled trial. It is a truly experimental study, and the reason it's an experimental study is because investigators are exerting control over the exposure assignment of each study subject, preferably through randomization. In all experiments, not always possible, but in a randomized controlled trial, they did use random processes to assign treatment to the study subjects on the study. It's prospective because obviously you define your study population, you randomly assign them to one of several different treatments or control, and then observe them getting the treatment and observe their eventual outcome. So it's prospective observation. You're actually following them forward in time. The direction of inquiry is also forward in time because you start with the exposure or the treatment assignment and you look to the outcome. One of the benefits of the randomized controlled trial, that's not always the case in other studies, is that it has a concurrent control group. And that means the control group is being quote-unquote treated and observed simultaneously to the treatment group or groups. And so these are the types of studies that can actually be designed to test for cause and effect relationships. It's the only kind that can. So this looks a lot like a design we saw before, only now the key is we're randomizing. We're exerting control over which subjects are exposed and which are not exposed. Notice, not all scenarios, not all research questions would allow this to happen. So some scenarios, even though this is the gold standard by which we measure all evidence, sometimes it's not possible, which means we never discount any study as long as it's rigorous. The key here in a randomized controlled trial is randomization. Randomization ensures that the two groups that we're comparing, if it's just two groups, randomized controlled trials, by the way, can contain more than two groups, but the two groups of patients are similar in all respects with the exception of the treatment that they receive. The idea here is if they're homogeneous at baseline, all coming from the same population, they are observed in the same way, all other extraneous factors are either recorded or controlled for, then if we see a difference in their outcomes between these two groups, we can be reasonably assured that we can attribute it to the treatment, because that's the only thing between the two that differs, theoretically. There's always a chance, because no study can investigate every possible source of variation. So again, randomization is this important concept. Why do we randomize? Here's an example in coronary artery disease. Suppose we want to compare surgery to a drug. We know that major heart surgery, we're a physician, we know major heart surgery is invasive and complex, and we worry about some people dying during surgery as opposed to actually dying from the disease. So if we brought that thinking, if it was necessary to bring that thinking into this study, then we would assign patients with less severe disease, either on purpose or not, to the surgery group, and people with more severe disease who we think might be at higher risk of dying during the surgery to the drug group, which might be necessary based on your question earlier. Again, limitations of the context, but randomization would protect us against this first bullet point. If we get to the end of the study, and the study was designed to determine whether or not there is a difference in patient survival between those who receive surgery and those who receive drugs, this study can't answer that question. Even if it finds a difference, it's inconclusive. Why is that the case? Because you have two sources of variation here that are confounded. One is the treatment effect, the other is the effect of the severity of their disease. So when two things are confounded, it means it's impossible to separate their effects on the outcome. So when you see a shift in the outcome, you have to say, well, it's either the treatment or the disease or a combination of both. But this study can't answer that question, and good luck getting that published. So a study would be inconclusive and a waste of time, money, and patience, if that's what it was designed to do. Randomization would fix that. It's critical because there's no way for us to be aware of all possible confounders. Observational studies have little to no formal control for confounders, so we can't conclude cause and effect based on their results for that reason. So randomization forms the basis of inference. The strengths of randomized controlled trials, they truly minimize the impact of bias. We have control groups, we have random assignment, many times we have blinding. We also have prospective observation, so there's some assurance that there was a uniform application of the treatment and a uniform observation of all patients on study, regardless of what their treatment was. It also definitively establishes the temporal relationship between exposure and outcome and can actually demonstrate cause and effect. Weaknesses is that it's not always feasible nor ethical. It's very resource intensive, and like any prospective study, you have attrition. So you'll have missing data due to loss to follow-up. At the very top of this pyramid, we have systematic reviews. Systematic reviews are narrative syntheses of the current state of evidence. So if someone does a systematic review, they identify all the high-quality research evidence relevant to a research question, and then they summarize it in a particular way. There are guidelines for performing these systematic reviews, but generally they are a narrative, and they come to a conclusion about the current state of knowledge. These are very important because there are many different primary studies going on, and some of them are conflicting. So it's important for researchers who are well trained to critique the literature. You can say, you can potentially identify reasons why you may have two primary studies with conflicting evidence. And systematic reviews, that's really their purpose, is to try to summarize the current state of knowledge.
Does it involve statistics?
Not necessarily. If you do a meta, and this is not really projecting well, the meta-analysis is the statistical aspect of a systematic review. So a meta-analysis attempts to do what a systematic review does narratively, only using statistical methods. So it will take the actual results from two or more primary studies that addressed the same hypothesis or research question in roughly the same way and attempt to kind of average out the overall findings to give an overall estimate of the treatment effect from multiple studies. This is usually done using analysis of variance techniques and regression techniques. It doesn't have to be randomized controlled trials because not every field has the ability to do randomized controlled trials. I think what it does, the purpose of it is to classify all the existing studies according to how strong their evidence is and try to identify sources of variation between studies. Why did so-and-so's study differ so greatly from this other person's? Is it because there's a potential source of bias? So it's just trying to walk readers through where they think the current state of knowledge is, and how strong that knowledge actually is. There may still be a lot of uncertainty in the research question. The meta-analysis. The key to the meta-analysis is that you really want studies that are very similar. So you can do, I mean, if you incorporate preferably randomized controlled trials. Preferably the control groups for all the randomized controlled trials are the same type of control, and the treatments are all the same type of treatment, and they're all administered in the same way with the same kind of follow-up, but that never happens. So there's tools that we use to try to help explain some of the variation in trial results based on design features and get some kind of overall estimate. But yes, the quality of the systematic review, I shouldn't say the quality of the systematic review. The quality of the conclusion is determined by the quality of the evidence that the person who wrote it found. So if the evidence is lousy, the systematic review probably tells you that it's lousy, which would be a good systematic review, but again, it would come to a conclusion with a lot of uncertainty. But if there's a lot of really strong evidence, then the evidence from the systematic review should represent that strength. Meta-analysis is the same. Its strength relies on, it's like garbage in, garbage out kind of stuff. Okay. Couple of funny slides. Again, I told you I made some changes. Here's a funnier one. So this is random medical news. I think it's funny. I really feel bad for people who don't have training, who don't for instance, if you know someone, if you have a personal relationship with someone who's not necessarily a scientist, they're very intelligent, I'm not saying they're not intelligent, but not a scientist, who's undergoing treatment for cancer, how do you explain all the conflicting, they're getting, and Google, Dr. Google, you can find anything out there. So it's a joke, but it's sad. It's like let's just flip the wheel here and figure out what causes what and who, what population, and then tomorrow we'll change it. And then I thought this was funny. Statisticians have jokes too. I used to think correlation implied causation. Then I took a statistics class. Now I don't. And then the other guy says, sounds like the class helped. The other guy says, maybe. Everyone get it? Correlated, maybe not causal. So, funny jokes. Make sure people wake back up. So, why is there conflicting evidence? I went to a talk probably 7 or 8 years ago by Gary Gronzeth called The Way Physicians Think. And it really got at the key reason why there's conflicting evidence. It's because it's not black and white. There's always uncertainty associated with the results of every study. Every study has limitations. Every study has context. What one designs to produce evidence for and come to one particular conclusion may not occur in another study designed exactly the same way in the same population. It could be identical and still get different results because of something called sampling variability. Their sample was a little bit different than mine, and it was different enough for us to come to different conclusions, which is why small studies where sampling variability has a huge impact have to be taken with a big grain of salt, because they could actually show an effect, a statistically significant effect, in the totally wrong direction. So the idea here behind Dr. Gronz's talk is that a decision, whether it be in clinical trial research or in just treating a patient, is built on a foundation of not just evidence, but also of training and principles and some subjective judgment. So we have to acknowledge these three components. We tend to focus so much on the evidence. And unfortunately, the literature can be just as confusing as it can be illuminating, because there are a lot of poorly designed, poorly executed, and properly interpreted studies out there, which is why it's on you as a researcher to make sure you're trained in evaluating the literature. So I'm glad that you're coming to classes like this, and I hope that you'll continue to try to refine that. One of the best ways, I think, to become a better researcher is to peer review, because it forces you to think about what other possible things could have caused what they found. And it's a skill that's not always pre-existing. It's one that may have to be refined. There are other reasons why there's conflicting evidence. One of the biggest is publication bias. So there's been a lot of actually what's called meta-research, research about research, that shows that people who do studies, when they get a non-significant result, non-statistically significant result, they take a lot longer to publish it. And in fact, some of them never publish it for many reasons. We can talk about those reasons, but some of them are on the shoulders of the actual researcher. Some of them are on the shoulders of publishers. So it's a tendency to submit and publish positive studies with statistically significant findings over ones where P wasn't small enough. Conflicting evidence can also come simply as a function of noise, which is sampling variability. I did an experiment, you did an experiment. We did them identically. Our samples were randomly drawn from the same population. They're theoretically representative, but I got something very different than you did. And that can be completely explained by sampling variability, especially in really small studies. So small studies are problematic. They're necessary, but they're problematic. Multiplicity in testing, what I mean about multiplicity in testing is something called everyone heard the term fishing for a result. We'll talk a little bit about the impact that has on the p-value next week, but that's a very bad thing. Conflict of interest. And then, of course, there's a great variety and flexibility in the different types of designs. So there's homogeneity or differences in study results that could be simply a function of the study design itself. This is a great read in PLOS Medicine, Why Current Publication Practices May Distort Science. I encourage you to read this. It's not new. It's from 2008. But Dr. Ioannidis, I believe I'm saying his name correctly, is a meta-researcher, and he's published quite a bit in the realm of the quality of research. He does research about research. Here's another one by the same author from 2005. It's kind of controversial, but it's a really interesting read. It's a very thought-provoking read about why most published research findings are false. So I don't know what he means by false, because do we ever know the truth in science? But it's a very, very interesting read. And it's interesting to see how he got to his conclusion about the problem with what's been published. Now again, this is, 12 years old. So we've done a lot of improving since then. Another thing that I think we have to at least make a statement about is the p-value, which we'll talk about next time. But it's been under some attack in the last couple of years because of misuse and misinterpretation. And I would encourage you to click on the link and read the American Statistical Association's statement on p-values. And then you can even go to Nature and Science and read what they're talking about p-values. But what I'll try to do next time is give you the real world meaning of the p-value and show you why maybe some of the things that you do in practice are bad when it comes to p-values, and p-values shouldn't be used. So critical evaluation of the literature. You have to assess the validity and relevance of the study. There are a couple of ways of doing that. Is it in a quality journal? Is it peer-reviewed? There's a problem with that nowadays. How does the location of the study reflect the context or the generalizability of the findings? Does the sample reflect the actual targeted population? Is there any conflict of interest? Is the study sponsored by an organization that may influence the design or results? And is the intervention feasible? So they did a clinical trial to show that it worked, but can it be implemented? Maybe it costs too much. It'll never get paid for by insurance companies. I don't know. There's feasibility issues as well. And maybe it's not available or wouldn't be available because of cost issues. One of the key underlying things is understanding how to select the proper study design, a randomized controlled trial, cross-sectional, case control, based on the intent of the study. So there are different types of studies based on their intent. You can be testing the efficacy of a drug treatment or a surgical procedure or some alternative method of delivery of medicine. Those therapeutic trials should be done in a randomized controlled fashion. There'll be pilots that occur first, but the standard of evidence should be RCTs. A diagnosis study, a study whose intent is to diagnose, could be a cross-sectional survey because you're really just trying to demonstrate whether a new diagnostic test is valid. Screening studies demonstrate the value of tests which can be applied to large populations and which pick up disease at a pre-symptomatic stage. That could be a cross-sectional. Prognosis would be one where you're trying to determine what is likely to happen to someone whose disease is picked up at an early stage. That's longitudinal cohort, prospective cohort potentially. And causation is determining whether a harmful agent is related to the development of illness. This is not my term. I don't like the term causation. What they really mean is association. But they're just trying to link effects to link exposures to eventual development of illnesses. So then you can assess the validity of the design based on its intent. What was the study design? Is that particular design appropriate and optimal for what they're trying to do? Are all participants who entered the trial accounted for in the conclusion? I am regurgitating the consort guidelines here. Because in the consort guidelines, you have to actually have a patient flow. It's a figure 1 to say who was approached, who was screened, who was eligible, who enrolled, who was randomized, who was treated. If they were lost to follow-up, how many were they and why were they lost, or did they not complete treatment or not get their outcome measured? All of those things are recorded in that figure. What protections against bias were put into place? How similar are the groups at the start of the study, and were the groups treated and observed equally? I have an example in my own experience of a biased result that came about in a treatment comparison simply as a function of how frequently study subjects were being observed. They were being observed much more frequently in the treatment group than in the control group because they had to come back and get treatment more frequently than the control did. And so, of course, you're recording many, many more adverse effects because you're asking them many, many more times, did you have this? How did you feel yesterday? Whereas in the control group, you're relying on a week's or 2 weeks or a month's worth of recall. So naturally, you confound the treatment effect with the effect of observation there. And then if the results are statistically significant, if they report a p-value that's small, what's the actual effect that they're trying to convince you is important? Is it clinically meaningful? If the study did not show statistically significant results, is it because there didn't appear to be a true underlying effect, or was it because maybe it was too small? It was underpowered. And then were there other factors not accounted for that could have affected the outcome, which gets to your statement about limitations. What if they measured it but didn't report it or adjust for it, or what if they just didn't have access to it? So again, all of the different ways to critically evaluate an article. This is a 2006 article that I really liked. The reference is there. Some common analysis methods, and then we're almost done, and we'll pick up with actually performing some of these methods next week. So when we get to data analysis, our focus up to this point has been, let's do the study the right way. Let's design it. Let's plan it. Let's conduct it in the right way. Well, when we get the data, We have to analyze it in some way. So how do we determine what the appropriate data analysis is? Well, ask yourself these questions. What's the research question? What's the data? What kind of outcome do I have collected, and how is it collected to address the question? Is it nominal, ordinal, interval, ratio? Is it continuous, categorical, those kinds of things? So understanding the information contained in a data point is vital to understanding which of the techniques or tools available is appropriate. How many groups do you have? So in other words, what's the design of your study? Is it a randomized controlled trial? Is it a case control? Is it a cross-sectional? You might not even have groups. You might have a single population. You're just looking for associations, which again gets back to your research question. If you do have groups, you need to understand whether or not they're independent groups, like in a randomized controlled trial, or if the groups are dependent in some way. Maybe you have matched cases and controls, or maybe you're, another example of dependent groups could be a pre-post type of analysis where the two groups are actually the same people. You're just measuring them before the intervention and after the intervention. So you need to match up their information. And then, of course, what's your sample size? Because if you have a small sample size, a lot of the methods that you learn in an undergraduate stat course might not work well. They might make errors more often than you think they're making them. So small samples, you can use non-parametric methods. And all these methods are just a set of tools that make no assumptions about what the data look like. They don't assume normality. They don't assume equal variances in the groups, for instance. They're suitable when you have small sample sizes, but they're also suitable if you have a really large sample and the data just doesn't behave nice. It's really skewed and you can't fix it. So it can be applied in that case as well whenever you can't meet the assumption of the t-test or of the linear regression or ANOVA or whatever you want to do. In general, non-parametric methods, the way they work is kind of like how the median works. The median ignores the actual value of the data and just focuses on its ordering within the data set. Non-parametric methods in general do the same thing. They use the rank of the individual data values as opposed to the actual data value itself. So you get the rank order of the observations and maybe do like an ANOVA on that or a t-test on that, as opposed to doing it on the actual data value. The downside to these, they're robust, so they perform very well when you have small sample sizes or when your assumptions are violated, but it does come at a cost. Let's suppose you have two groups, your data is normally distributed, you have equal variances, the t-test is appropriate, but you decide for some reason to do the non-parametric equivalent of that instead. What you'll end up with is a less sensitive test for the treatment effect. It's like 5% reduction in the power. So it's a more conservative look at a treatment effect if the parametric test could have been performed. If the parametric test shouldn't be performed, then it just shouldn't be performed. You should do non-parametric. And I keep referring to parametric. This is all the stuff that you've seen before. Chi-square, T, F. You know, you make assumptions about the distribution of the data, and these are really only suited for sample sizes that are large enough to assess whether or not this distributional assumption is met. So if you have a sample and you need to make sure it's normally distributed and you plot it with a QQ plot or a histogram, which we'll see next time, and you can't tell, then that's a key, that's an indicator that your study is not big enough to do the method that you're testing the assumptions for. So the different types of tests that are often employed, if you're comparing two groups, maybe their response rates, which would end up being percentages or proportions, you can do the chi-square test. You can do a Fisher's exact test, which is a non-parametric test. You can do what's called logistic regression. It's a regression model where your outcome is yes or no, binary, responded, didn't respond. So it's just a regression model. You might want to compare the two groups' response rates while adjusting for the age, for instance, and that a regression model would be appropriate there. Two independent groups and you're comparing their averages, their means. The two-sample t-test or ANOVA is the most commonly applied method. You might want to also adjust those comparisons for other variables through some kind of regression technique. That falls under the umbrella of linear regression, but specifically it's analysis of covariance. It's just regression. And the non-parametric comparison is the Mann-Whitney test. There's a couple of different non-parametric tools, but that's the one that you see. It's sometimes referred to as Wilcoxon. And then two independent time-to-event outcomes. So this is survival analysis. Very often you see the log rank test, which is a non-parametric test, by the way. But you can also do Cox regression, which is it's actually modeling risk over time. And of course, any of the adjustments to the treatment effects that you might want to incorporate in the modeling process can be done with regression models. And I'm going to get through I'm going to skip through clinical trial phases. Feel free to read that. It's pretty straightforward. But I want to go through at least one example of how do we determine the sample size in a simple scenario. So this is not necessarily to give you the ability to go and power a study. It's to hopefully help you understand the necessary pieces of information and how they play a role in determining the appropriate size of a study. So the things that we have to take into consideration are, how are we going to analyze the data? What's the hypothesis that we're testing? What effect are we looking for? So that revolves around the concept of power. Another consideration is just logistical. So can you actually get that many patients, and do you actually have enough money and time to do a study of that size? The key, though, is we want the minimum number of patients required to achieve our principal scientific objective. We don't want to do too many, then we would be overpowered and we might start modeling noise, finding things that aren't actually there. There are two different ways, two different goals that you might want to achieve in a study, and depending on your goal, it will depend on the approach that you take to determining the sample size. You might be doing a more descriptive study. In that case, you're interested in identifying associations, in estimating effects, in generating hypotheses. You shouldn't be doing hypothesis testing. So that's what's called an estimation trial. Those kinds of studies, the sample size calculation comes from the interval estimate, the confidence interval for the treatment effect. Because we all understand that as we increase the number of patients that we get on our study, we decrease the sampling variability. And that's what the confidence interval is giving us, right? The sampling variability, the quality of our estimate. So there's a relationship between how big the study is and how precise our estimate is that we use for those kinds of studies. Hypothesis testing is based on power. Our ability to detect a signal and reject a null hypothesis. The size of the clinical trial, real quickly, we'll do this again next week, but I want to make sure that we understand the type 1 and type 2 error rates. These are two different kinds of errors that we can make in hypothesis testing. One is a false positive finding and one is a false negative finding. So when we talk about the level of significance of a test, it's kind of how comfortable are we with making this kind of error kind of thing. And then the power is what we usually report with the type 2 error, because the power is 1 minus this error rate. False positive, false negative, true negative is 1 minus the false negative rate, which is what I just stated here. So the things that we usually power a study for this is when my brain stops working, is right here, right? We're usually, if you're, again, familiar with hypothesis testing, usually our null hypothesis, we aim to reject it, because then that supports our scientific hypothesis, which is generally the alternative. So if we're after this conclusion, then we want to know the probability of making the decision, this conclusion, under two different states of truth. whenever our scientific hypothesis is correct, that's the power, 1 minus the type 1 or type 2 error, and when it's not correct, when the null, that there actually is no difference. So what's the chance of concluding that there's a difference when in fact there's not, and that's the type 1 error rate. This one is usually maximum of 5%, sometimes 10%. This is usually a minimum of 70, 80, 90%. Setting any of those three determines the fourth. So if you set the type 1 error rate, and you set the power, and then you set what difference you're interested in detecting, I need to see a 20% increase in the response rate. That's the minimum amount I need to see before I determine this is clinically important. Then that information will allow me to calculate the number of subjects you need to achieve that goal. Depending on the nature of the outcome, you could actually do a similar approach with the confidence interval. So this is not power here. This is the precision based for the estimation trial. If you know the level of significance, you can actually find the relationship between the number of subjects and the margin of error, or the width, precision of the confidence interval. So either way is an approach that's feasible. So here's a quick example where we want to detect a difference between two treatments. The primary objective is whether or not a treatment changes an outcome. It improves it, for instance. One thing we have to know is that the outcome is continuous. This is not, yes, the disease resolved, or no, it didn't. It could be something like HbA1c. The study design is a randomized controlled trial, so study subjects are randomized equally to one of two groups, treatment A or placebo. We're going to observe them and then record some measure of the benefit of this, which is the HbA1c, and compare the average response of subjects on treatment to those on placebo. And we'll do that using a two-sided t-test, and we're going to a priori determine that we want a 5% level of significance. I don't want to make a type 1 error. I want the chances of making a type 1 error to be less than 1 in 20. So this is all happening in the design phase. How do I go about determining what size the study needs to be? Well, there's one approach. I need to understand what kind of results I should expect in patients who are getting the control or getting the placebo. For instance, maybe I know that they should have on average a response of 10. And then I have to understand the difference that I wish to detect. Now there's two approaches to this. This is the ideal thing, that you know what a clinically meaningful difference is between the groups. But that's not always the case. So then you have to think about, well, what's a feasible sample size and what does that allow me to detect in terms of the difference? Those are two approaches to get to the same end. Suppose you do know that it's clinically interesting to be able to determine if treatment A changes the response by 10%. So if the real difference in responses between the two groups is at least 10%, so a mean response of 10 in placebo, 10% increase would just be an increase of 1, would result in a mean response of 11 in the treatment group. Or if the change is in the other direction, it could be a decrease of 1, which would result in a mean response of 9. I would like to be able to flag this as statistically significant at the 5% level. In other words, I want to be able to get a p-value less than 0.05 if I get evidence demonstrating at least a 10% difference between these two groups. I would also like my chances of finding that difference to be really high. And that's the power. That's 80%. So I set the power at 80%. I set the type 1 error. I set the difference I want to detect. I know I'm doing a t-test. The t-test is math. There's a formula and there's a point-and-click software that will allow you to put these things in and get the estimated sample size back out. So we have two hypotheses. Equivalence of the groups versus their responses are unequal. Type 1 error, power, and the difference of 1. Here, the effect size this is one approach to determining what difference would be clinically meaningful if you don't understand or if there's not enough information about what could be clinically meaningful, and that's in the form of an effect size. Cohen's d is one of these effect size measures that allow us to kind of skirt around specifying the clinically meaningful difference, because it specifies the difference between the two groups and scales it or standardizes it by some measure of the noise in the data. The reason this is useful is because this thing right here, the noise in the data, is what we anticipate the noise in the data to be. And we don't ever, might not know that. If the literature is not clear what this thing should be, it might be very hard to specify it beforehand. So going up based off of D as opposed to having to figure out what this difference is and what this is might be an easier approach to it, especially early on. Because Cohen's d is directly related to the difference in means, and it's also inversely related to the variability and the sample size. There is a kind of rule of thumb. I know everybody likes rules of thumb for small, medium, and large effects. So if we use Cohen's d based on preliminary data, let's say we're interested in detecting a difference of 10%. Let's say we do have preliminary data and are allowed to estimate that variability in the data, that noise of about 2.1. That results in a Cohen's d of 0.476. You can find online different tools that will allow you to enter in these values and get out a sample size. In RStudio, that function is the power.t.test function, and it can compute the required sample size. I'm not going to, because of the sake of time, I'm not going to actually open up RStudio like I had intended and show you, but just know that when I put those numbers into the function, it tells me that a minimum of 71 subjects per group is required to achieve power at this level of significance for the effect that I'm after, assuming that I've specified the noise in the data correctly. So there's a lot of ifs there. If we observe a difference of at least 10% in the data, that corresponds to that clinically meaningful difference. And again, if all those other assumptions that we made to get to that sample size are pretty accurate, the test we do is likely to produce a statistically significant p-value, a p-value less than 0.05. It's not guaranteed, but it's likely. The reason it's not guaranteed is because of something called sampling variability. However, if we observe a difference smaller than that 10%, or if maybe one of our assumptions that led to that calculation of the required sample size is way off, we might actually be underpowered. And then we're likely to produce a p-value that's larger than that. So you can see here, just for a moment, and we'll get into this again next week, the p-value is a function of the design. It can't be used, it can be, but it shouldn't be used and interpreted if the study is not a designed study, if it's not powered. Yes?
Is it appropriate to monitor your assumptions and your variability of procedures during the clinical study? Because there's no point.
Correct. So the question is it appropriate to maybe monitor over the course of a study as the data is coming in whether or not the assumptions that you made are accurate or way off? Because you might know halfway in that, oh man, I'm way underpowered. Yes, but there are certain design techniques that we have to put into protocol and follow to make sure that that is done in a scientifically valid way, that don't invalidate the results. So the answer is yes. There are different approaches, but if you've ever heard of an adaptive clinical trial, has anyone ever heard of an adaptive clinical trial? It's beyond the scope of this class. Just know that it does that. It monitors and adapts in a scientifically valid way that protects the type 1 error rate. to achieve power because your assumptions may be off. I'm going to skip this. There's a power calculation tool, if the link still works. It's really neat to play around with because it shows you the relationship between power, sample size, variability, and the difference. But the idea here is, I wanted to emphasize this for a moment, the term likely to produce, not guaranteed, but likely to produce a p-value either smaller or larger than 0.05. The p-value is a measure of, is dependent and a function of sampling variability. And what it's trying to quantify actually is the sampling variability here, and in some way. So it can, even when the truth is there's a 10% difference, you might be dealt a bad hand, I think is the term, and get one of those samples that is actually randomly selected appropriately that results in data that's very unusual. And that would be the case where you might not get a p-value less than 0.05 even if you powered the study. So, uncertainty in everything. Yes? Mm-hmm. Mm-hmm. No. No. You can, I mean, it won't tell you that. You can hypothesize that maybe your p-value, that maybe you incorrectly estimated the noise in the data. But again, it could just be all the time. Of course they do, which is why the p-value has a bad rep. It does. It has a, I mean, are you reading the literature about p-values? Science, Nature, psychology journals, they've rejected, I hate to use the term rejected, they have said you cannot publish null hypothesis significance testing in this journal. We will not accept it. And that's a little extreme in my opinion, but it's because we misuse them. We don't understand what they're telling us, and we misuse them. And that's on statisticians' backs for not doing a better job. I will say, if you have $25, I probably shouldn't say this on the recording, but I'm going to do it anyway. I'm not paid to say this. There is a book called The Intuitive P-Value Primer that everybody needs to read if you're doing research. Everybody. Read it. And then you won't have to come to this class again. Ever. Lem Moyer is an MD PhD, and his PhD is in statistics. So he understands the physician's perspective on these things. He understands that the p-value is a mathematical thing, but you can't talk to someone who doesn't have differential equations and calculus 3 and all this other stuff. You can't talk to them like they do, because it's like my mother-in-law, who's Greek, speaking to me in Greek and expecting me to understand what she's saying. It doesn't happen that way. He does an excellent job, and I've actually, over time, having read that book, changed the way that I communicate about things like the p-value, because he does it in a way that I think a high school student could. I really do think, and especially a physician. I don't mean to equate you guys with high school students. I don't mean that. I mean in terms of like mathematical, it's not mathematical at all. He puts it in the context of a real clinical experiment and shows you why the p-value is meaningless here, but has very, very strong meaning and is a very valid measure of the strength of evidence in other circumstances. So that's my recommendation for the day. And I think you can get it online for free for PDF, but I would encourage you to buy it. Okay, so intent to treat analysis is another design tool, but it's actually an analytic tool that we use to help minimize the impact of bias. And we use it in prospective studies when we have loss to follow-up. So in a lot of randomized controlled trials, patients drop out or they die before you can measure their outcome, their response to treatment. And so that missing data, think about the bias that could happen. If a patient who's receiving a treatment dies before you can measure their outcome, it could be that that's a random thing, or it could be that it's non-random, that they actually died because that treatment's riskier. It has more horrible side effects. Or the disease, yeah. I mean, there's lots of reasons, but the idea behind an intention to treat, and the intention to treat principle states that you analyze as randomized. So you attempt to make every attempt to capture everyone's outcome data, whether they received treatment according to their assignment or not. Some people get randomized and never get treatment for whatever reason. So what it does is it gives you, I think, a clearer picture of maybe what the actual effective treatment would look like in the real world, because you acknowledge the fact that there are going to be people who don't adhere to treatment perfectly. They're going to take medicines that they're not supposed to take that are going to interact with it. Those kinds of things. So it's just it attempts to account for the biases or minimize the impact of the biases on that estimate of the effect of treatment in the way that we analyze the data. That's the intent to treat analysis, where you analyze as randomized. And then there are some other things that you have to do. You might have to actually make an assumption for people who maybe died before you could observe their outcome. Maybe you assume, if they're in the treatment group, you assume that they didn't respond, because that's kind of counter to what your hypothesis is. But you don't do it? You have to define in your protocol ahead of time how you're going to deal with missing data. Yeah. If you just say intent to treat, it's not always clear, because there's actually lots of modifications to it. Like, how are you going to record an outcome for people that died before they finished treatment? You know, so you have to, the intent to treat principle requires you to have outcome data on everybody. And so whether that's imputing, estimating what their outcome would have been, I mentioned a conservative way is to just assume they didn't respond, which is kind of a conservative. If you're expecting them to respond, assume they didn't, because that will dampen down what effects that you see in the actual data that you observed. The opposite of that, or the alternative to that, is what's called a per protocol analysis, which gives you, it kind of gives you an over enthusiastic view of treatment. Yeah, you should. You should think about those things beforehand, because what you don't want to happen is you've got the data and there's all this missing data, and now I don't know what to do, and I, as a human being, want to do the thing that's going to give me the best outcome. So to take that off my back, I want to know what I'm doing before I know what the data looks like. And mathematically, if I were to do it the way I mentioned, human nature-wise, then I would invalidate the results of your study. It would invalidate it. Because if I'm going to produce a p-value, that p-value requires everything to be pre-specified. None of the analytic plan can be random, which means it can't be a function of the data. We went way over. Any other questions? Well, I think it was great conversation today, and I will send out updated slides, and we'll pick up next time with hypothesis tests and actually do some